expectations as well. I feel about 80%, maybe 75% today, but we'll get through this. First, I need someone to volunteer to remind me that my phone is charging over here, and I have this on. So what I don't want to do is walk out with my phone charging. Several people came up to me after the earlier talk, and I think I probably confused some of you a little bit, so I'm going to spend the first 2 minutes. I was lecturing on hemodynamic monitoring, and the point I wanted to make about intrathoracic pressure, with PEEP being, of all the things we do with the ventilator, what produces the most increase in mean intrathoracic pressure. And that is, if you're in a zone 3 and your PA catheter wedge pressure is actually a real wedge pressure, meaning the column of blood is open, and you're mechanically ventilated and on PEEP, you are accurately measuring the left heart pressure. It's just that the distension of the ventricle that you get for that pressure is much less than it would be if the patient was spontaneously breathing, because that outside pressure is restricting the filling, because you fill the ventricle based on the transmural pressure. Totally independent, not my assignment, is to talk about cardiopulmonary interactions as it relates to mechanical ventilation, which is a different issue, which is that mechanical ventilation and PEEP will raise the right heart pressure through the pleural space and the juxtacardiac space and the thin wall right atrium, such that your gradient for blood return to the right heart is decreased. So you get decreased cardiac filling with intrathoracic pressure increases, and that will reflect over on how much blood is now getting over to the left heart. That's a separate issue from the measurement issue, which is all that I tried to cover in my talk on hemodynamic monitoring. So now, life-threatening hyperglycemic syndromes. What happens in diabetic ketoacidosis is that cells are unable to use glucose. Homeostatic mechanisms kick in order to provide alternative fuels for the body. Remember, glucose is the primary fuel for energy. These alternative fuels, ketone bodies, are produced. Counter-regulatory hormones drive these ketone body productions, which are needed, including glucagon, cortisol, catechols, and growth hormone. Precipitating factors for DKA include infection, stress, and noncompliance. Presentation is classically emesis. Altered mental status based on how much volume depletion, age of the patient, how high the osmolarity is, tachycardia, leukocytosis. Leukocytosis may be present in the absence of infection, as may abdominal pain, weakness, and hypotension. The pathophysiology of DKA is linked to two things: the osmotic diuresis that is producing intravascular volume depletion and loss of electrolytes, and the ketoacidosis associated with ketone body productions. Diagnostic criteria for DKA, there are only two that have to be present. You have to have an increased anion gap, and you have to have positive serum ketones. You usually have hyperglycemia, and you usually have decreased pH. Rarely you may see someone who's continuing to take their insulin, titrating their insulin against their blood glucose, maybe a pregnant woman that's got a high GFR that may present with euglycemic DKA. Decreased pH, I see a couple of cases a year with patients come in with normal pH and occasionally even slightly elevated, because the first thing that grabbed a hold of their body was the contraction alkalosis and the loss of HCl from nausea and vomiting before the DKA came in. We'll talk about that a little more with some case examples. There are a lot of interesting formulas that are useful in clinical practice and very easily testable on boards. One is, what will the sodium be after I correct my glucose to my target? Because remember that the body pumps sodium out in response to hyperglycemia in order to try to maintain extracellular osmolarity. And you can predict what the sodium will be after the glucose comes down because we know how the body handles pumping sodium out of the extracellular fluid as the glucose rises. And the formula for what the sodium will be after you take the glucose to, say, 200, as the example shows here, there's a 1.6 decrease in sodium for every 100 rise in glucose. So if you're targeting a 200 glucose in your patient, you look at the current glucose minus 200, that's your target, divided by 100. And then multiply that by 1.6. For example, if the glucose was 750 and your target was 150, when you got to 150, you would anticipate that the sodium would have risen 6 times 1.6, about 10. That also allows you to calculate your free water deficit, because once you know what the sodium will be approximately after a particular glucose target, that tells you how much free water that you have lost if it's in excess of isotonic fluid. First question, which one of the following is most correct concerning issues related to serum ketones? The serum ketone assay at most hospitals does not measure acetoacetate. Acetone is an acid. The anion gap is a better reflection of successful treatment of ketoacidosis than the serum ketone level. And acetoacid is metabolized to beta-hydroxybutyrate. And the great majority got this correct. Acetone is not an acid. In fact, I'll show you that beta-hydroxybutyrate is metabolized in the body to acetoacetate. Both of those are acids. When it goes from acetoacetate to acetone, it's no longer an acid. So to clear the ketoacidosis, the anion gap, you need to drive everything down through acetone. However, you're measuring acetoacetate and acetone. And in patients with DKA, the initial ratio of beta-hydroxybutyrate to acetoacetate is higher than normal. So what happens as you successfully treat DKA, you're driving everything down to the bottom of this and you're decreasing your anion gap. But since your assay is measuring your bottom elements, the ketone level in the blood may be deceiving. The rationale for calculation of the anion gap during treatment of DKA is a better marker for successful therapy, is it's a better reflection of the ketoacidosis. And also, if you're using normal saline as your resuscitation fluid, you almost certainly are going to get some degree of a non-anion gap metabolic acidosis, and we'll talk about that a little more. Here's an example of a patient that presents in DKA with the bicarb of 8. You can see that the anion gap there is 118 from 135, which is 17. If you calculate the delta gap, and I think you've already had some session on that earlier, the delta gap tells you what you would have predicted the bicarb would be. So you take the normal anion gap from the anion gap, and that gives you, in this case, a 7. And if you take 7 from a normal bicarb of 24, you would have predicted the bicarb would be 17, but in actuality it's 8. So it's a lot lower than you would have predicted just for the ketoacidosis. And therefore there has to be a non-anion gap acidosis present. And it could be from diarrhea, it could be from saline resuscitation, but it is present. Normal respiratory compensation for DKA, the one that you can always remember, as you would anticipate a spontaneously breathing patient to be able to hyperventilate down the PaCO2 to the last 2 numbers of the pH. So if the pH is 7.25, you would anticipate hyperventilation down to 25. There's also a Winterbauer formula that you're probably not going to remember for a long time, which is to take the current serum bicarb times 1.5 plus 8 plus minus 2 as what you would predict adequate response would be from hyperventilation as far as PaCO2. I mentioned earlier you occasionally will see alkalemic DKA. You almost always see a post-resuscitation non-anion gap acidosis with normal saline. This is thought to be due to a narrowing of the strong ion difference due to the aggressive normal saline resuscitation. Although no one has ever shown that non-anion gap acidosis is clinically significant, on occasions individuals will choose to switch over to lactated ringers during the resuscitation period in order to control that non-anion gap acidosis if you're giving a lot of liters of fluid. This is an example that I use to explain why this occurs. The difference between the sodium and the chloride, those are the 2 strong ions in the body, is about 40. So someone that had a sodium of 145 and a chloride of 105, and you give them a lot of normal saline, which has a 154 of sodium and chloride, and when that mixes, and this is just a chalkboard example of what happens if you mix 1 liter of normal saline with 1 liter of normal electrolyte level plasma solution, and you can see that what you come out with is your new sodium and chloride of 148 and 121. So you've decreased your strong ion difference from 40 to 27. And when you decrease that, it increases the ionization of water and increases H+. Fluid therapy, the typical DKA patient is down about 5 liters of isotonic fluid plus additional free water. Insulin therapy, 10 units IV push. Our endocrine colleagues would tell us you don't need to give anything out front, that majority of patients you can take care of just with the continuous infusion. In the typical DKA patient with pHs less than 7.25, you'd want to target a 0.1 unit per kilogram per hour continuous infusion insulin. You may need to increase the insulin if the glucose is not decreasing, but we'll go over this again. Remember, your primary reason for the insulin therapy is to target the ketoacidosis, not the hyperglycemia. Elderly individuals, you use half that continuous infusion. Why? Decreased muscle mass. So that's where insulin acts. So you don't need as much insulin in the presence of decreased muscle mass. When the glucose gets to 250 to 300, you begin glucose infusion. Basic tenets of therapy is the insulin therapy to correct the ketoacidosis and the glucose supplemented to maintain your glucose in a non-hypoglycemic area in the process. This may require D10 or even D50. A couple of amps aren't going to have any significant impact on your treatment of this disorder. You stop the insulin therapy only with symptomatic hypoglycemia. Otherwise, you just give glucose. Insulin rate, when the pH is 7.25 to 7.3, or the anion gap is equal to or less than 15, since in many cases we don't follow arterial blood gases in most of these patients. We'll talk a little bit about venous gases toward the end. When the anion gap is cleared, or if you choose to measure serum ketones and they're negative, you discontinue the IV insulin, but you leave it running for a couple of hours to give your sub-Q insulin a chance to work. There are studies to show that if you're very meticulous, and this is very resource consumption, a lot of resource consumption, that you can treat DKA with sub-Q 1 hour insulin and produce the same results, but it requires much more resources. You initiate potassium when potassium is known or suspected to be equal to or less than 5 in the presence of acidemia. These patients are typically massively total body potassium depleted, yet you may be looking at a normal or even increased potassium. But as you institute fluid resuscitation and insulin, the potassium is going to drop like a rock. The more aggressive the IV fluid infusion, the greater the need for potassium. And if the potassium is less than 3.3, it's recommended that you actually put some potassium on board before you start your fluid resuscitation and insulin. Bicarbonate therapy. Concerns with bicarbonate therapy, which back in the 70s, early 70s, bicarbonate therapy was routinely used to treat DKA. Now it's not. There are only rare exceptions when you would want to give it. You worry about paradoxical lowering of intracellular pH, and we'll talk about that a little bit later before we finish. You worry about a shift in the oxygen dissociation curve to the left, which would interfere with oxygen offloading in these critically ill patients. You worry about sodium overload, and primarily I worry about precipitation of hypokalemia. If the pH is critically low, less than 6.9, in general, it's recommended to give bicarb, perhaps 100 millimoles over 2 hours, and in between 6.9 and 7, 50 millimoles over an hour and a half. Phosphorus is often low in these patients, and it may make sense to use potassium phosphate to replete both of these electrolyte abnormalities simultaneously. What about urine versus serum ketones? If urine ketones are negative, that rules out DKA because you can't have ketoacidosis with negative urine ketones. However, the converse is not true. You can have positive urine ketones and not have ketoacidosis. So it can be used in the emergency room example for screening tests. Venous versus arterial blood gases. Remember that in patients that are not in shock, the venous and the arterial pH are close. And there'd be no reason why you couldn't use venous arterial blood gases to track your progress in the acidosis in this patient. In adults, there's thought to be no risk of cerebral edema with rapid lowering of blood glucose. It is in pediatrics. The primary reason you don't want the glucose going down like that is it certainly identifies patients that are more likely to have symptomatic hypoglycemia. Let's move on now to hyperglycemic, hyperosmolar state, how HHS differs from DKA. So let's move to our next question. Which one of the following is not true concerning the difference between DKA and HHS, hyperglycemic hyperosmolar syndrome? Glucose is higher in HHS, the serum osmolarity is higher in HHS, pH is higher in HHS, or potassium is higher in HHS. I predict about 90% on this one. Remember, we're looking for the not true, the one that's not true. I got 50, whatever. So let's talk about these and why the answer is potassium is higher in HHS. So HHS is typically a disease of type 2 diabetes as opposed to DKA with type 1. Patients tend to be older, often nursing home residents that haven't had a lot of access to fluids. Alteration in consciousness is much more frequently present. The glucose is higher, usually 600 or greater. Serum osmolarity is higher, usually 320 or greater. The bicarb is usually not as low, typically 15 or even higher. Mild ketonemia may be present, but it's not a strong driving force. And the serum potassium is usually lower because this particular process is associated with a lot more osmotic diuresis than the typical DKA patients. These patients are almost more of an intravascular volume depletion problem, more so even than insulin. If you reestablish intravascular volume, often the patient's own circulating insulin will handle most of the problem with any acidosis that may be present. Prognosis is typically determined by the underlying predisposing conditions instead of the ketoacidosis, and mortality is higher than DKA. Treatment is more volume, less insulin. You'd never start more than 0.05. Some people might even use less. And some people would initially just give volume therapy only just to test the waters on what's going to happen to glucose and to any acidosis that might be present. Let's move on now to lactic acidosis. This is an 1843 book published in German by a guy named Joseph Scherer, who was the first person to describe lactic acidosis in medical illness. He drew a specimen from the heart to measure lactate in a woman that had died, 23-year-old female with puerperal septic shock, likely strep pyogenes, and did a chemical analysis of blood directly from the heart, which revealed lactate. I promise I'm not going to make any small points about this, but we all learn this in medical school. It actually does have relevance for this particular disorder. Normally, we use aerobic metabolism of glucose to generate energy. When we use anaerobic glycolysis in the presence of inadequate oxygen in the tissues, we generate lactate, and we, in the process of generating the lactate, which is the salt plus the H+, we generate the H+, and we produce lactic acidosis. Type A lactic acidosis is from the anaerobic glycolysis. This is the tissue hypoxia, hypoperfusion. It's very prognostic. Whether it's driving anything of its own right is questionable. We'll talk about that. Improvement in sepsis-induced lactic acidosis correlates with survival, and a lactate greater than 4 is recommended as an entry criteria for early goal-directed therapy. What we've all seen occur in our hospitals over the last 6 years or so is serum lactate is now being frequently measured in patients that come in with infection, and occasionally we're finding some surprising elevated levels in patients that are not hypotensive. Type B lactic acidosis is seen in the absence of tissue hypoxia or hypoperfusion. Congenital metabolic disorders, hepatic disease related to clearance, remember the liver clears the lactate, and acute leukemia. It's also seen with the wide variety of medications, nucleosidic reverse transcriptase inhibitors, so patients on AIDS therapy can come in with lactic acidosis type B, epinephrine, metformin, particularly in patients that are developing renal insufficiency, methanol, cyanide, ethanol, salicylate, and interestingly, it's a measurement artifact with the assay with ethylene glycol. The question is, with type A lactic acidosis, it's clearly a sign of tissue hypoxia, but is it in its own right producing any injury to the body? We do know that if you take patients that have lactic acidosis from shock that are on vasopressors, and you treat those patients with an equimolar amount of saline versus sodium bicarb, so they get the same volume expansion. The group that gets the bicarb, the pH goes up. It doesn't in the patients that just get the saline equivalent. The filling pressures go up about the same thing. The cardiac output goes up about the same thing. And most interestingly, it has no effect on vasopressor dosage. So this is down to a pH of about 7.2. Some of these patients were 7.15. We all get nervous. We each have our own threshold for the pH that makes us nervous. And for me, it's often the pH that's making the nurse nervous. So that I will empirically give bicarb with pHs typically less than 7.25 on most days. If you elect to give sodium bicarb because you can't reverse it, in other words, you're doing everything you can to reverse the underlying process, to optimize blood flow to the tissues, and you still have that low pH in the lactic acidosis, the recommendation would be that you give it by continuous infusion. If you think about how bicarb buffers, the bicarb combines with the H plus to produce carbonic acid, and that dissociates into water and CO2. So in order to get the buffering, you've got to bring that CO2 back to the heart from the tissues. You've got to bring it through the lungs, and then you've got to expire the CO2 to complete the buffering process. The concern is that if you bolus a lot of bicarb into the peripheral tissues with tissue hypoperfusion, you may get CO2 out there that you can't get back. And that may go intracellularly and therefore produce a paradoxical intracellular acidosis. That's the chalkboard rationale for using continuous infusion. Going to move on now to case vignettes of hyperglycemic syndromes and hope my voice holds out. 28-year-old male with type 1 diabetes mellitus developed nausea and protracted vomiting. This continued for 2 days, during which time his usual insulin therapy was discontinued. The following laboratory values were found on hospital arrival: serum sodium 146, potassium 3.3, chloride 92, glucose 525. The bicarb is buried down at the bottom there. It's 24. The BUN's 31, pH 7.41, pH CO2 of 39, PaO2 of 82. So this is a real case, and it has a very important teaching point about it. Which one of the following best describes this patient's acid-base disorder? A, metabolic acidosis. B, metabolic alkalosis. The Dion-Sanders approach, both, or D, neither. And majority of people got the right answer. This is a patient, short story, is a normal serum bicarb, but a very prominent anion gap. And you do see this in real life. You see it on boards. So this patient has a predicted serum bicarb of 4 with an anion gap of 30. in a normal bicarb. So how does this happen? It happens because somebody develops a profound metabolic alkalosis and then goes in to DKA. Real life boards. Take-home message is on boards in real life, even if the bicarb is normal or elevated, you got to check anion gap. A patient with DKA is admitted to the ICU for monitoring and aggressive medical therapy. Initial serum ketones are positive at a titer of 1 to 16. The repeat serum ketones after 2 hours of aggressive therapy reveals a continued titer of 1 to 16. The anion gap has decreased. Okay, we're not going to do this interactive, but I did want to review this. The anion gap is a better reflection of successful treatment of ketoacidosis than the serum ketone level. The patient's DKA has improved. Why? Because the anion gap is decreased. Acetone doesn't contribute to the anion gap. It's not an acid. And acetoacid is not metabolized to beta-hydroxybutyrate, as we mentioned earlier. The next case, a 22-year-old, 60-kilogram woman with type 1 diabetes, no comorbidities, admitted to the ICU with DKA and altered mental status. Her initial pH, 7.04 anion gap is increased to 24. Bicarb is 10. Serum glucose is 520. She gets 3 liters of normal saline, 10 units of regular insulin intravenously. A rate started at 6 units that is based on 0.1 units per kilogram per hour. After 2 hours, her laboratory results show a sodium of 140, potassium of 3.5, chloride of 112, a bicarb of 10, and a glucose of 95. Her mental status has improved, and the urine output is 1 cc per kilogram per hour. And again, we're not going to do this interactive in the interest of time. But I'm going to go back to the question because what I wanted to do is to put all the information up that's needed to select the correct answer. So the anion gap has gone from 24 to 18. So we're making progress, but we still need to continue our continuous infusion insulin at the initial target dose. The sodium bicarb has not changed, so we're getting a non-anion gap acidosis from the normal saline. The glucose has not only gone down, but it's bothersome down. So this patient needs glucose. And the sodium is 140, so we don't want to start giving a lot of free water yet. And we've only given 3 liters, and we said typically it's 5, and we still have a significant anion gap. So 3 of these are wrong because we're either decreasing the insulin dose or stopping it. 3 are wrong because we're going to half normal saline, and we don't need it yet with a sodium 140, and we still have an anion gap of 18. So the answer that doesn't have any wrong things in it is the first one, which is continue insulin at the current dose, give D10, and start some glucose running, and mix in a little bit of lactated ringers, and still give a pretty hefty hourly dose of fluids. A 32-year-old female is admitted to the intensive care unit with diabetic ketoacidosis. She has depressed level of consciousness, and her glucose is 560. The serum sodium is 145, and the BUN is 60. Let me define something for you so you're not working from an unfair advantage, and then we'll go to the question. Effective serum osmolarity is a term that means the extracellular osmolarity as it influences cerebral water content and cerebral function. So it's how the brain perceives extracellular osmolarity and how it affects fluid movement out of the brain. So now you're ready for the question. Do you have that up? Okay, so I'll go back to the case. Okay. The timer going? Okay, interesting. I think the best answer is B, although after that question this morning, let's see. The calculation of effective serum osmolarity, I'll show you the formula, but it's not 10 that you divide the glucose by for the calculated osmolarity. The calculation of effective serum osmolarity should exclude BUN. That's true. Why do you exclude BUN if you're talking about how the brain reacts? Because urea is ubiquitous. It moves across all cell membranes. It has no influence on water movement. It has no influence on anything. It just moves around. Calculated appropriately, an effective serum osmolarity of 310 supports hyperosmolarity. Is the cause of altered mental status? No, we'll cover that. The adjusted serum sodium should be used? No. You need to use the current sodium because that's the real sodium. So here's the formula: 2 times the sodium plus the glucose divided by 18 plus the BUN divided by 2.8 plus the ethanol divided by 4.6. But for effective serum osmolarity, you take the BUN out. It's just the sodium and the glucose, and if there's any ethanol. Our patients calculates to 311. So is a serum osmolarity of 311 a potential reason for the altered mental status? No. You need about 320 or more. Okay. I'm going to finish with simplified ICU management, a primer for the boards. This is something that I have updated over the years from an initial Rosenfeld publication. Intubate and attach the trachea to any ventilator that resembles the front cockpit of a Boeing 777. Adjust respirator so that pH is 7.4, PaCO2 is 40, and PaO2 is 100. Insert arterial line if the MAP is less than 60. Infuse albumin, crystalloid, dopamine, dobutamine, levophed, epinephrine, levosimendan, low-dose vasopressin, and stress-dose steroids. There's no need to waste time thinking about what form of shock is present. These drugs will cure all of them. They have been conveniently premixed in a gallon jug for ready infusion. If heart rate's less than 50, give atropine. If heart rate is greater than 135, give metoprolol IV. It is advisable to keep MAP raising solution on hand when using the latter. Insert rectal tube. This keeps sheets clean, the laundry happy, and most importantly, makes rectal exam impossible. Insert NG tube. Infuse Maalox through the NG tube. The resultant diarrhea maintains good flow through the rectal tube and prevents clogging. Insert a PA catheter. Keep the CVP at 8 and the wedge at 14 with appropriate solutions. Fresh bottles of CVP raising solution are infused through the CVP port, and wedge raising solutions through the distal port. If these pressures rise above the stated levels, blood is sucked out of the appropriate line with a 50 cc syringe until the pressure normalizes. Be alert, this may require RBC replacement. Alternatively, premixed combinations of mannitol 20, Lasix 120, Atacrit 100, Bumex 2 may be given as a combined bolus. A hearing aid is provided by manufacturers for use with this solution. Although keeping the CVP at 8 and the wedge at 14 simultaneously is difficult, remember this is your most important job. All else pales in comparison. Insert Foley catheter. Keep the urine output at 40 plus minus 2. If less than 40, use the balanced diuretic solution mentioned above. If greater than 40, tighten the adjustable clamp on the Foley to reduce the flow rate. Start low-dose heparin, add pantoprazole, famotidine, besiotidine, protonics, or lobitotics. Administer cefepime, amikacin, linezolid, meropenem, trimethoprim, sulfa, zithromycin to everyone, whether they need it or not. Put the dialysis team on standby. Cultures are not needed with this regimen as it kills all organisms. If white stuff forms in the mouth, add fluconazole. Consult the nutrition service. Start enteral feeding. When diarrhea develops, switch to half strength and decrease flow rate. When diarrhea persists, switch to isoosmolar. When diarrhea continues, switch to parenteral nutrition. When volume overload and hyperglycemia develop, discontinue infusion. It is now 10 days later, and patient is either recovered or deceased. Keep away from the patient. Do not perform a physical exam. You will only get tangled up in all the lines and tubes and trip on a wire. Also, eye patches, TED stockings, and bunny boots make exam difficult. Always keep in mind that your patient might be dead. This is easily overlooked. The respiratory makes it look like he is breathing. Pacemakers keep the heart beating. An arterial pressure reading of 0 is assumed to be merely a clogged or kinked line. Peripheral pulses are unaccessible due to bandages, lines, and hematomas. Don't be fooled. If in doubt, ask. Thank you.